everyone has access to these recommendations. And, that's 30 years of expertise and knowledge that has been generated and continuously is generated. And that just means that the next generation of patients with the cancer my dad had, or even for that matter, the cancer my mom had, are going to be better off.
I would also say this is a great example of the power of volunteers. NCCN is a volunteer organization, and our panel members and people who participate in other NCCN activities devote thousands and thousands and thousands of hours every year.
There are now 88 guidelines, and they cover an increasing spectrum of not just adult tumors, but supportive care guidelines and pediatric cancers.
Every study that I'm aware of looking at cancer clinical practice guidelines demonstrates that the NCCN guidelines are the most widely utilized guidelines in the US and outside the US. All of this serves to increase the quality of cancer care wherever the guidelines are used.
One of the things the NCCN does very well is keep up with the innovations that are coming our way. As cellular immunotherapies expand and new FDA approvals come on board, the NCCN guidelines are updated annually. There are many oncology societies in the United States. Some of them are professional societies, several nonprofits, but the NCCN stands above these in my mind with regard to its influence not only on actual daily practice, but also patients' perceptions of what we do, and also with government policy.
NCCN is recognized nationally, not only by CMS, Centers for Medicare and Medicaid, as a reimbursement model, but also by Congress, where the NCCN breast cancer screening and diagnosis guideline was recently held up along with the American Cancer Society's breast cancer screening guideline as an evidence-based model for women for the early detection to improve their outcomes if diagnosed with the disease.
NCCN offers the ability, whether you live in the most rural part of the United States to the biggest city in the United States, to receive the best data-based, research-based practice and treatment for all cancers that providers might treat. The stretch and reach of NCCN is absolutely incredible, and you think about that both nationally, but internationally as well. Cancer care is going to change dramatically over this next decade and beyond, and to have an organization dedicated to making sure that the best care possible is provided to patients, but to do that in an equitable way, to make sure that access is available, and to make sure that these resources are available to all patients and their providers. That's an incredible mission, and very excited to be a part of it.
And I see the future of cancer therapy continuing to be bright, where we are better able to personalize the treatment of a particular cancer for the patient in which that cancer presents.
I think it's going to become more difficult for the community oncologist to integrate all of the latest information. That's where the NCCN guidelines will play a really important role.
How do we ensure that our guidelines are getting to everyone? And then how do we include the other social factors within our guidelines that can help individuals?
When I think about the future of cancer care, I envision a future where we catch cancer early when it's most treatable, and we can make the most impact on patients' lives.
For the clinician community, knowing what people in the large academic cancer centers are doing and largely why they're doing it, which comes from the manuscript portions of the guidelines, is very, very important. People are treating wide numbers of diseases, and they can't always keep track of what's going on in some of the ones that they don't treat every day. So it's really great to have available to them really authoritative information.
Well, I think every journal has to step back and assess the landscape and decide what's important now. One of the things that's so pervasive now is AI. I mean, it's permeating every aspect of our lives. And so I think keeping current with what people are interested in is probably the most important thing an editor-in-chief can be doing in terms of positioning the articles in every issue to sort of reflect what people are interested in.
You know, one particular thing that I am sort of most excited about is also the health equity report card and the health equity focus that NCCN has really stood up and supported. And I think the NCCN's sort of focus on health equity and understanding that there needs to be intentionality validates and actually supports the broader sort of understanding and efforts in this space.
My thought is that the best way to practice good cancer care is to make doing the correct thing or the right thing the easy thing to do.
I think we look forward to another 30 years of continued success and continued growth, and hopefully bringing some good to the world and helping in the fight against cancer.
Happy anniversary, NCCN and NCCN Foundation. I'm incredibly proud to be a part of this organization.
Happy anniversary, NCCN. I've been so proud to be a part of this organization for many, many years, and I look forward to many years coming.
We want to wish everyone at NCCN and everyone that supports its activities and its mission happy 30th anniversary.
All right, I'll wait for you in the back. Good morning. Thank you for joining us this morning in sunny Orlando, Florida. In the early 1990s, a group of academic institutions came together as the National Comprehensive Cancer Network to develop standard treatment protocols that would set the national benchmark for excellence in cancer care. These standards would enhance and control the quality of cancer treatment, efficiently use available resources, and improve cancer-related outcomes. A statement of principles declared that NCCN is an alliance of cancer center providers organized to, quote, develop and institute standards, guidelines, and systems to ensure high-quality, cost-effective care, end quote. A press conference in January 1995 announced the creation of NCCN with 13 inaugural institutions nationwide. The first NCCN clinical practice guidelines in oncology were published a year later, and the annual conference, where attendees gathered to learn about the latest advances in cancer care and guideline recommendations, was born. Fast forward 30 years, and here we are again, gathered to learn about the latest advancements in cancer care and guideline recommendations. Instead of just annual updates, NCCN's library of guidelines are updated on a continuous basis, with a record 241 updates in 2024, across the library of 88 guidelines. NCCN offers a suite of products now to support the delivery of quality and effective cancer care to everyone, including compendia databases and chemotherapy order templates that delineate guideline recommendations and safe delivery of anti-cancer systemic therapies that are included in the guidelines. Continuing education programs like this one that promote learning across the oncology provider spectrum, and research, policy, and global programs that support efforts to promote learning across the entire world. And guideline concordant care. We remain committed to our mission of defining and advancing quality, effective, equitable, and accessible cancer care and prevention for all people so that they can live better lives. We hope that you, our oncology colleagues, will join us in that effort through the use of the content and products that we have, and look forward to learning with you about the latest oncology advances this weekend. Celebrate our 30th anniversary with us and enjoy NCCN's 2025 annual conference. Thank you for coming. At this time, I'd like to turn it over to Dr. Jessica Vanderlyn from NCCN member institution Siteman Cancer Center at Barnes-Jewish Hospital and Washington University School of Medicine. This is our first plenary session. Enjoy.
Thank you. Hi, I'm Jessica Vanderlyn. I'm a clinical psychologist at Siteman Cancer Center and Washington University School of Medicine in St. Louis, Missouri. I'm also the co-chair of the Distress Management Guidelines for NCCN. I have a couple of housekeeping things, so let's start with that. I'd like to remind you to log into the conference app to download the presentation handouts, complete session evaluations, and view accreditation information. If you have any technical support questions, email conference@nccn.org. And now we can get started. So when I was asked to moderate this plenary session and put together this talk, addressing mental health and cancer care, optimizing interdisciplinary psychosocial support, I was really excited. I love to talk about the work that I do. I love the care that we're able to provide patients. And I really love getting to share this specialized field of psycho-oncology with the broader oncology community. I was also very appreciative of NCCN choosing to start the conference with this very important mental health conversation. Additionally, I was thrilled that I got a chance to invite some colleagues up here with me to share the work that we do. And not only are they fantastic experts really in their field and different organizations and hospitals throughout the US, but they're really fantastic people too. So I will let them introduce themselves and then we'll get started with a conversation. There will be time for question and answer at the end, so don't hesitate to, at that point, step up and ask some questions, but we all could talk about this for hours if you let us. All right, go ahead.
Hi everyone, I'm Stephanie Simolovich. I am indeed the founder and executive director of Young Adult Survivors United. We are headquartered in Pittsburgh and our focus is on young adult cancer diagnosed between ages 18 and 45 as well as supporting their caregivers. I'm also up here as an advocate. In August I will be celebrating my 20th leukemia anniversary as a young adult, so it's a privilege to be here.
Good morning, everyone. My name is Tamron Fowler-Gray, and I'm an assistant professor at UNC School of Nursing in Chapel Hill, North Carolina. I'm also a researcher at UNC Lineberger Comprehensive Cancer Center, where a lot of my work focuses on supporting family caregivers impacted by cancer. It is an honor to be here today. A lot of my experiences come from my work as a bone marrow transplant nurse, and those patients and families have really inspired me, so I'm happy to be here.
Good morning, everybody. I'm Jesse Fan. I'm a psychiatrist. I'm the medical director for psychosocial oncology at Fred Hutchinson Cancer Center. I'm also a professor at the University of Washington's Department of Psychiatry and Behavioral Sciences. I'm a health services researcher and also direct the clinician scientist training program in our department at University of Washington. Thank you.
Great.
Good morning. My name is Amy Corvaline, and I'm an oncology social work manager at the Dana-Farber Cancer Institute. I've been in oncology social work for almost 20 years, and I have a strong interest from the work that I did at Mass General Hospital with Dr. Kelly Irwin and working with patients with serious mental illness and cancer.
I'm so glad you all could join me today and that we can have this conversation. So I have a few questions just to kind of start us off, and I'd love to hear from your perspective how you view this work that we do. Okay. So the first question I have, in general, what role does mental health care have in oncology care?
Well, I can start. I think it's absolutely incredibly important. It is, when we look at a whole person and a whole patient, it's the most patient-centered approach to be thinking about someone's mental health history, where they are currently, and then as we think, towards survivorship, and I know Stephanie will talk about this, where people are headed. I think that as we think about mental health and cancer coming together, we know that distress is higher when people are diagnosed, but we also have learned that people who have pre-existing mental health issues may be more likely to struggle throughout the process, and that has an impact on their outcomes. It has an impact on their families and the people who are supporting them. So I think it's incredibly important to take a look at that mental health piece side by side with the cancer care diagnosis.
Yeah, I'll just add, cancer is obviously stressful for all patients and families involved with their care. And, our role, I think, is really to help people get through their cancer treatment and through survivorship. And I see one of our most important roles is to help our oncology colleagues help their patients get through things. And when a person has mental health concerns and challenges, that really gets in the way of their being able to get through their cancer treatment smoothly and continue to do things that they enjoy doing during their treatment and beyond. So I think that's one of the main reasons mental health is so important.
And I'll also add that a cancer diagnosis is another life event. It's another life stressor for individuals and families. And they don't necessarily know how they're going to respond until it happens to them. We also, as clinicians, have to understand that people start out on different playing fields when it comes to how much stress they can take and what their coping mechanisms are. So that's really important to evaluate at the onset of a cancer treatment journey. It's also important to recognize that mental health needs will vary across the trajectory from the early diagnosis period, even to the active treatment, bereavement, survivorship. So the mental health needs of patients and families is ongoing and quite dynamic, depending on what's happening in that moment.
I like that you brought up the family piece. I think we'll talk about that a little bit more, because families, not just their patients, are truly impacted by cancer.
I echo all of them, and as the survivor on the stage, it's traumatic. A cancer diagnosis, you are immediately grieving who you were. You are grieving what you think will be in the future, and you have no idea. A lot of times, patients are diagnosed, and they just want to know, what's the end game? The first question is, am I going to survive this? So you're facing your own mortality, and I think that's just the most important piece, if not one of many today, is that mental health needs to be as equally important as the cancer diagnosis and your physical health along with it. And a lot of times, people don't know the history of an individual if they have a history of mental health, and what does that look like? What happened in their life before a cancer diagnosis? And as Tamron said, when treatment ends, nowadays people ring the bell, and that's another point of a diagnosis when you really have to focus on the mental health. So there's just so many transitional points that I think we always need to make mental health a priority in someone's cancer care.
Yeah, I appreciate everything that you said, and bringing up that transition to survivorship is a real peak in distress in cancer care, and we often think about it just as a celebration, but I want to remind you all that it is a really challenging part of cancer care for patients. I also want to highlight what you said, Amy, that people come to cancer with I think we all touched on this, with all sorts of backgrounds. So somebody coming into a cancer diagnosis with a serious mental illness of severe depression or schizophrenia or psychosis, they have specific needs too that are not often met in the cancer center. In addition to that, we have all of these responses and reactions to cancer that range from a little bit of distress and healthy coping to a more serious mental illness. And all of that needs to be addressed. We really cannot have comprehensive cancer care if we're not including mental health care. So to move on, what are some general mental health or psychological responses to a cancer diagnosis? Let's start there.
Sure. It's interesting that Stephanie brought up grief, because I talk about that so much with patients, and my staff talk about that so much. I think that, the response is shock, anxiety, fear. So many of those basic emotions and that fight or flight are opened up and activated when you hear those words. And, you know, patients talk about thinking like not just only about the diagnosis, but, you know, what's going to happen with my bills? What's going to happen to my family? My son is starting college. We just had a baby. My mother is ill. I need to take care of her. And so we know from studies around what patients can absorb in those moments when they first hear that they're diagnosed with cancer, that they're absorbing very, very little. And you probably experience that in having to kind of repeat plans and directions, because I think that people just cannot absorb this information. And I think that for even people who don't have a pre-existing history of depression or anxiety, this can absolutely activate a piece of this trauma that, you know, impacts the way they are going to view their, you know, what's ahead of them in their treatment plan. And so, you know, I think, you know, when you're thinking about someone who has a pre-existing mental health difficulty, like, you know, they are really almost always focused on, what about my mental health? What if I get more depressed? What if my psychosis returns? Things like that. And so I think it's starting every conversation without even saying it out loud, if that makes sense.
So we mentioned grief, pre-existing mental health, kind of a natural response of shock in cancer. What else?
I'll add some other presentations. People often present with physical symptoms. People don't often come out and tell you, you know, I'm depressed, or I'm anxious, or I have fear of recurrence. They often will present with, you know, nonspecific somatic symptoms, you know, pain, fatigue, which are obviously common in cancer treatment, but also, you know, headaches, abdominal pains, things like that we often work up and find, you know, maybe there's no clear underlying physical reasons for these symptoms. And, you know, I would just encourage everyone to kind of be on the lookout, because that's how, you know, people often present with their psychological or emotional stress. And there are a lot of cultural kind of differences in how people, you know, present with stress. And but a lot of times they don't come out and tell you. It's great when they do, but often they don't come out and tell you that they're suffering from depression or anxiety.
So as a nurse, I spend a lot of time with patients when they're very vulnerable. 4 a.m., we've had a lot of 4 a.m. patient and family calls. When I was working in pediatrics, I was mainly talking to parents and guardians in the middle of the night when the child is asleep in the bed. And we will have conversations including the parents thinking backwards on, should I have seen the signs? Did I miss something? Why did I not catch this? I've even had parents who were clinicians themselves, kind of blaming themselves. There is such a roller coaster where a lot of times I see them activated as problem solvers and information gatherers at the beginning of a diagnosis. They're like trying to and we know this in the literature, they're gathering as much information as possible to be able to find something to hold on to and something to help them better understand that diagnosis and, you know, what the next steps are. But a lot of times for me, I remember administering chemotherapy right before a transplant to a young patient, and the mom, she looked at me when we're in the middle of hanging chemotherapy, and she says, wait, should I be doing this? And this was not the first round of chemotherapy. So the child had already had chemotherapy, but for some reason that day, she felt such angst and a little bit of hesitation, and we know that it's hard to really backpedal, especially depending on, you know, if it's a bone marrow transplant, for example. It's hard to backpedal once we started giving chemotherapy. But I say all that to just kind of acknowledge the fact that we have to meet our patients' families where they are when they're facing this diagnosis, and recognizing not everyone's going to be readily accepting the diagnosis. They may, seek out answers from other places. And we just have to understand, what they're feeling, where they're coming from, and finding the best way to support them, because it may be extra information, it may be, I need a moment, I can't absorb any more information.
In addition to all of that, we see a lot of anxiety. I think you touched on that, Jessie, and fatigue. You also touched on that, but those are really core things that your psycho-oncology team or a mental health professional that works with you can support in our patients, and those are some of the most common and most distressing areas of dealing with cancer. Another question I'd love to hear from you, Jessie. Are there any specific challenges, specifically in the medical clinics, when it comes to assessing and addressing mental health or psychosocial needs of our patients?
Oh, where do you start? The challenges range from, at the very beginning, identifying people who are distressed and having the people to address, adequately address the issues that are brought up. I think that the NCCN has done a wonderful job with practice guidelines for distress. I think the biggest challenge is, for any given healthcare system, how do you not only identify the distress, but once you identify it, how do you manage it to the best of your ability that can monitor a person's distress, make sure that treatment gets started quickly, that follow-up happens and is tracked on a systematic basis. And then one of the biggest challenges is finding ways to make treatment adjustments when things are not going as planned, which we all know in medicine often doesn't go as planned. So I think those are the biggest challenges, from a health services standpoint, kind of making sure that what you start is working, and that we make the treatment adjustments over time that are needed to make sure that people are getting better and their quality of life is optimized.
I think on a very practical level too, there's just a lot of time constraints. Clinics are very busy, so taking a moment to assess early on and repeatedly distress in cancer feels sometimes like it's this time that you don't have. It is so essential though, and really in the long run might save time, might improve treatment, might save time. And there's also stigma. So would anybody like to respond to that as a potential barrier?
That was on the tip of my tongue. Let's just say we have to remove the stigma. Mm-hmm. I know that some questions are hard to ask, about infertility and financial concerns. And I think across the board, patients feel isolated and then they feel dependent on others. And that's a burden. And so remembering to ask the hard questions, I think, is so important too, throughout the whole experience, treatment and afterwards. So why there's still a stigma when it comes to mental health is beyond me, but I understand that professionals are there to do their job, right? We all play a role in this, and so maybe not having the time, like you said, to ask those questions, but then who can? Who should? And I think we'll get into this a little bit, but I think, a lot of times the social workers and the nurse navigators and the psychologists, they're understaffed. And so if they don't have the time even to dive into those hard questions, remember the community resources that are available, the community organizations, because that's why we all exist, to take some of that burden off the staff that is in the cancer care center. I'll let anyone else add to it, but.
Absolutely, thank you. Any other thoughts on stigma?
I think that, one of the things that patients face is when you're coming in to meet with an oncologist, you know that they're seeing your medical record, your history, which isn't always an indication of who you are as a person. But I think when we think about stigma, I think about people who have had a substance use disorder, people who've had a pre-existing mental illness, people who have had other medical comorbidities, and how that's viewed. And I think that a lot of times there can be a lot of shame that people feel about their medical history. So just keeping in mind, that all of those things are happening while you're in the room with the person. And, that we really want patients to know that they can rely on this team that's here for them, that's made up of, social workers and nurses and psychiatrists and oncologists and nutritionists, that there's a whole team approach happening for them. And, I hope that is, a comfort to patients who are coming into a cancer diagnosis with other medical issues in their history.
And I'd like to also add, there's a term called buffering in the literature, and it references caregivers' role in cancer care, where they often try to be the protector of bad news and try to hold a lot of patients' feelings for them. But one of the things that is often in the back of caregivers' minds is if they have a mental health diagnosis, that impacts their eligibility as a caregiver, to be a caregiver. In some point, it impacts their ability to enroll in research studies if there's a diagnosis that could impede their participation in a study. And that goes for patients too. So I do think sometimes it's silenced because patients and caregivers are not sure of the ramifications and how it may impact the patient's outcomes and their participation, if it's the caregiver, their participation in the patient's care.
Excellent point. We know that distress or mental health concerns in cancer is underreported. That is very well known. The best that we can do is to continue to screen and assess and talk about it, to break the stigma, to ask in general how somebody's feeling, or how's your mood, or have you been quite anxious this week? I hear that from a lot of patients. You might just normalize that as part of your conversation when you see patients.
Can I just add really quickly that, there are a lot of misconceptions still, unfortunately, about what, a social worker's role is in the cancer setting, what a psychiatrist or psychologist. Is
that right, Jesse?
Yes. And a lot of times, patients will say, well, why do you want me to see a psychiatrist? You think I'm crazy, or why do I need to see a social worker? We hear that too, yeah. You're gonna take my kids away or something, I don't know. But
a lot of misconceptions.
I think the most important thing is to normalize it, and just, when you're with your patients, just say, hey, these guys are just part of our team. They're here to help you get through what you're going through, just like any of us, just like our pulmonary doctors or infectious disease doctors, and they're here to help you get through it, and they're going to help you get through it, and when you approach it that way, I think people are much more accepting of.
And I think it's important to use the name, the term that the patients and caregivers use. We may use anxiety, depression, but for some patients and families, they may say, oh, I don't have that, but I feel X, Y, and Z. We should be using those words when having conversations with patients and families in order to be able to keep the conversation going and to better understand their mental health needs.
Great points, thank you. How does actually assessing and then continually addressing the mental health care of our patients, how does that impact their cancer care? Are there specific outcomes that it can improve? I know the answer, but I'd love to hear from you what kind of things you see.
Well, I'll start in terms of outcomes. We definitely know in the literature when we are continually assessing mental health, assessing and addressing their mental health needs, then we're going to see an improvement in overall health-related quality of life. We're also going to see improved coping mechanisms, increased resistance, decreased anxiety and distress. and depression symptoms. We're also going to see improved self-efficacy as well. And for some, a better understanding of the future, less uncertainty in terms of their prognosis and knowing how to better address their goals of care. So we definitely see there's a lot of good outcomes when we assess and address mental health needs.
Yeah, I think
it's a lot. We gotta
there's a lot. Yeah, I mean, I think we all agree that people's quality of life will be improved if they're not as depressed or anxious. I think the less appreciated outcomes, positive outcomes, are that they actually adhere better to their cancer treatment. They actually complete their cancer treatment at higher rates. There's increasing data that mortality actually is improved, probably because of a lot of the better health behaviors, more better adherence, and ability to complete cancer treatment. But also, better family functioning, better return to work.
Yep.
All those things are improved with better mental health.
Yeah, for sure. And I think, we think about how it reduces caregiver distress. I think it also has an impact on the team. We think a lot more now about burnout and caregiver, not just caregiver distress, but that secondary trauma of being in this field. And I think when the mental health needs are managed, and we can see that as clinicians in the patient, and we see their caregiver feeling better and feeling more in control, I think that has a direct impact on how we view the work that we're doing. So I think it also has this direct line to a reduction in burnout and a better way of communication within our teams.
And I think a very practical piece of that impact the teams is sometimes fewer phone calls, fewer chats, because the patient's anxiety is better handled by somebody who's specialized in that, so they're not constantly coming back to their medical team with some of these pieces. That's a lot of the feedback that I get from the medical teams as well.
And for the administrators out there, fewer ER visits, fewer hospitalizations, actually decreased healthcare costs, even though you might be, seeing a mental health provider that tends to offset the costs of, an extra admission or an extra ED visit as well.
Length of stay, all of that.
Length of stay as well.
Yeah. So you brought this up earlier, Stephanie, specifically kind of that transition to survivorship. So as we talk about the mental health care of patients and the psychosocial needs of patients, we're not just focused on the time of diagnosis or active treatment. We're also focused on that time of survivorship, where there's often a peak in distress. Would anybody like to comment on that?
I just think it's a very significant transitional time, like I said, especially in adult cancer care. When you're finished with treatment, it's a celebratory time, but I have talked with patients and they literally go in their car and cry their eyes out because they have no idea what just happened, what's the next step, and you're almost like free to the world and you have no idea what that looks like and how it feels. Again, it's another phase of grief. And so I also think it's a time of identity crisis. Who am I? What am I on earth to do? I survived this. Maybe there's some survivor guilt in that as well. So there's all these different aspects that come to fruition in that moment. Again, I speak on behalf of the young adult population, but I think in general, there's a lot of guilt. Especially, I can speak personally about being dependent again on family to help you get to that point in life, and you have just survived if you are lucky to get to that point, and you feel like you owe so many people so many things, and that's not the case. But again, if we bring back that mental health aspect and support, what does that look like, and how can you better foresee that and have that perspective? And so I think it is so important at that moment in the transition into survivorship and throughout that you are connected to a therapist, a counselor of some sort, because I think everyone's experience is so unique. I think the perfect recipe is having that individual support, but also being connected to a community of others who can understand and relate, because you are in that next phase, and there are people out there who have gone through it and can help you through that next transitional time. So I think having being connected to the resources at that moment is crucial for survivorship.
Absolutely, absolutely. What I hear more often than not from patients is, I wish I would have heard about you sooner, so
I
you
hear it
could
all
have
the time.
helped me through this.
Yeah.
Right? It's not just, I wish that I had, had you take care of me when I was dealing with intense fatigue and all the anxiety around this diagnosis, but that transition period, they wish somebody was there to prepare them and help them through that.
I do think too, when you're in treatment, your blinders are on. So I think it's important to mention that there is support out there. There are others who can relate. And I think in the moment, you just need to get through that phase. You're not in the right mindset maybe sometimes. I have seen patients who are just diagnosed and they want to talk to someone who has the same diagnosis, similar in age, that can help them through, but then you are so busy and overwhelmed with everything you're going through and everything on your plate, trying to absorb it all, that maybe in those moments you're not ready. And I see a lot of people after treatment ends that they really need the support. Mm-hmm. So I think that's also important to note as well.
Great point.
Yeah, I would agree with that. I think, one of the things I hear from patients all the time is, I had all this support when I had cancer. Mm-hmm. And now everyone just expects me to go back to work, to just that things will go back to normal when this person's life is forever changed. It isn't going to go back to normal. And I think that a lot of patients feel like the support that they had from their community, from their family, has disappeared because the expectation is that you just move on with your life. And I think that, many times patients are very surprised that they feel much more anxious, much more depressed than they did when they were even first diagnosed, because there's just this sort of shedding of all of the support that people had.
I've had patients describe that as abandonment. Mm-hmm. They feel abandoned in that
That's
time.
a good word for it, yeah.
And abandoned by their loved ones who have been providing support and love, and also their medical teams. And that's not at all a criticism of those who are caring for the patients, but it is, it truly speaks to that significant change that happens from seeing your cancer team and having the friends and family taking such great care of you every day, to now only going into the clinic once every 3 months, and those friends kind of dropping off. So there's a lot that happens at that time.
And we also haven't talked about patients who are parents yet. Mm-hmm. So if you're diagnosed and you're a parent, going back into, you've been a part of the family, but kind of getting resettled back into the household and, learning to participate in pickups and drop-offs and soccer practices and meal times, cooking, and learning about those parenting tasks again, and learning how to get re-embedded into the family functioning is something that is an adjustment for both the patient, the parenting patient, and also the partner, the co-parent, who may have been the caregiver and may have not been the caregiver for that patient. The other thing to mention in terms of mental health and survivorship is for caregivers, and Stephanie mentioned this in terms of identity shifts, but what also happens is that because they're so used to caring for the patient, and when the patient no longer needs the same level of support, the caregivers are having to improve their communication and understanding and relationship with the patient, so they don't bump heads. But it is an adjustment for the caregiver because they're so used to having their schedules dictated by the patient's needs and schedules. So it's a lot to adjust from a family caregiver standpoint.
A lot of roles change.
Mm-hmm.
One thing that helps me kind of think about when people are at highest vulnerability for distress is, people tend to get distressed, particularly when there's unpredictability, and also decreased control. And it's those times of transition. We talked about, ending treatment, but, starting a new phase of treatment, a new problem that comes up, when there's heightened unpredictability and decreased sense of control is when people are going to be particularly distressed, and we need to be really on alert to look for it and address it as soon as possible.
And just to kind of shift to talk about some of the positive mental health aspects in survivorship, there's such an enormous amount, there's an enormous influx of gratitude and hope and optimism and wanting to give back after they've been through such an arduous journey. And I think that's not spoken of enough in terms of just the overwhelming sense of that they made it, victory in this journey as well.
And it's also okay if somebody doesn't feel that way, right? Emotions are very complex and complicated, so that maybe gratitude in one moment and intense anxiety and grief the next moment too.
I also think that sometimes the other thing that's really powerful is patients see from that gratitude comes this idea that there may be changes I can make in my life. Maybe I don't want to work in this career anymore. Maybe I want to travel. Maybe I want to have a family. I think that that's one of the most satisfying things as a clinician, is to see that this monumental event in someone's life has guided them to do something different, something new that could be potentially really wonderful for them.
And a good opportunity for general health behavior change, right? Somebody at this point is reflecting on a lot of pieces of their life, so they may be more motivated to do things like quit smoking. And unfortunately, we know that a cancer diagnosis does not make somebody want to or actually discontinue smoking. There's a lot of effort that needs to go into that, and often the psychosocial care can support those health behavior changes. I want to talk a little bit more about caregiving. So, Tamron, you're definitely an expert on caregiving, and I think we all treat caregivers, but I'm just wondering if anybody has any other kind of bits of information about caregiving, or how we address the needs of the caregivers.
I'll start. I could talk all day about this, but I think we'll learn from other colleagues too. I'll keep it simple and say it's important to acknowledge the person in the room with the patient. When I do my research studies and, it's in the hospital or in the clinics, and I'm approaching the patient to learn about who's in the room, and then introduce them to kind of the questions that I am investigating. And oftentimes the caregivers, the patients are shocked because they're saying, "Oh, you don't want to interview me?" But then the caregiver's like, "Oh, you want to interview me?" So it's a kind of interesting dialogue, because they're so used to being unseen but having to be present. They're a necessary but unseen presence oftentimes, especially in bone marrow transplant, where you must have a caregiver for eligibility. So I just think the first thing we have to do is acknowledge them in the room. So I'll start there.
Yeah, I think that's very true. And when I was working at Mass General with patients who have a serious mental illness, we were studying their caregivers, and one of the things that we learned is that much of the literature focuses on the spousal relationship as a caregiver, and the patients we were working with had adult children, siblings, close friends, maybe people from their community mental health network that were really those were the people that they identified as their caregiver. So I think, as Tamron was saying, really thinking about who's in the room with this person. Often we ask patients who do you call if you have a problem, or who do you count on? Because I think sometimes some patients have a really hard time kind of thinking about that word caregiver, and who is my caregiver? What do I really need a caregiver for? And I also just think really thinking about what is this caregiver going through. And it's difficult because, as Jessica said, time is a huge aspect of this. It's difficult to try to get everything through to the patient and also be thinking about the caregiver. But the caregivers, their world is completely changed as well, and they're not getting nearly the focus and attention that the patient is. And so really thinking about what goes on for their medical needs, their mental health needs. Do they have an understanding of what's going on with the treatment plan? I've talked with so many caregivers who leave a meeting and they don't understand what's going on. They still have questions, but they're too embarrassed to call and ask, well, what are these pre-medications, or what can he eat? And so I think really making it clear to caregivers, like, this is what we want you to do. We want you to call. We want you to reach out if you don't understand. And making it clear to patients that we care about everyone in your life. We want to know if things are going okay at home. You're coming alone to most of these visits. When we first met your partner at the beginning, what's going on? So I think just keeping all of those lines of communication open, which is really hard when you have a limited amount of time with that person.
Caregivers do so much work. It's the unpaid work, but they are caring for the patients that we share day in and day out, and there's a lot of data that shows that they are just as distressed. Some studies show they have higher anxiety than the actual patient. Yep. So if we're depending on these individuals to take care of the patients that we're also taking care of, I think we need to do a better job of addressing their needs too, or the patient doesn't get the care that they really need.
And recognizing that caregivers are also patients themselves. I wrote an article in Health Affairs about this, and this is stems from my own mother's story. When she's an author on it. She's okay with me sharing this. She was cared for by her PCP, and her PCP asked her, "Are you caring for anyone?" And that was one of the first times a healthcare provider had asked her as a patient if she was caring for anyone. So I think it's important to remember that, these caregivers have health needs themselves. They're often seeing or skipping their health appointments because of the patient's appointments. And they also don't necessarily like the term caregiver. So for me, I'm a bereaved caregiver, a daughter. My dad, I lost him about 2 years ago of a quick Hodgkin's lymphoma diagnosis. And I was a distance caregiver at the time in Boston. So while not in the room every time, I was on the phone calls whenever, when he was rounding, when the team was rounding with him, on the phone, video, and also driving down 14 hours at least every month and staying for 2 weeks at a time. So although you may not see the person present, they're very much present. I was following up on his notes electronically, asking questions. And also to say that the person who's in the room isn't necessarily the caregiver either. They may be the person who gave them the ride that day. So there's just assumptions that we have to really make sure that we acknowledge as clinicians when we see certain people with the patients or not with the patients.
Great. So shifting gears a little bit, what are some models of mental health care or psychosocial care that are most effective? I'd love to hear from, we have a range of kind of experiences here. I'd love to hear from you all.
I can start. As you know, this is a passion of mine to think about the models that are going to help, cancer centers of really diverse, makeups and staffing, and I think, an interdisciplinary model is really the best model. And difference between multidisciplinary and interdisciplinary is that, multidisciplinary models have different disciplines, different providers, but an interdisciplinary model is where each discipline works really closely and in coordination with each other, where the sum is greater than the individual pieces. And the most evidence-based model is called the collaborative care model, which really is a team-based approach that takes multiple disciplines and makes sure that they work together, kind of like pieces of a jigsaw puzzle, so that they're all adjacent and in coordination with each other to make sure that every patient is identified, through screening and other methods, and then and then seen through the whole trajectory in a population-based approach, so that people who are not necessarily the ones making the most effort to ask for help. We all know that a lot of the people who need the help the most are not the ones who are asking for it. And so a population-based approach through an interdisciplinary model, like the collaborative care model, I think is the most effective and cost-effective way. And I can talk more, on and on about this, but I'll let others talk about it.
Yeah, I might have to arm wrestle you for it. It's a huge passion of mine too, and Jesse has been a consultant both at Mass General when we were forming the collaborative care model for patients with serious mental illness, and now in my role at Dana-Farber, we're implementing the collaborative care model throughout our institute, but it started in the regional sites where I am a supervisor, and you really do get to see firsthand how it opens so much up for patients, where they now have access. At Dana-Farber, our model uses palliative care, psychiatry, psychology, social work as sort of the first line and assessors of the patient. I think that it gives patients a sense of security because they don't have to think about, I have to go to all of these different people and places and no one's communicating. Healthcare in general has a very siloed approach. We have our mental health here and our palliative care here and our cancer care here. And I think this is a model that really brings everyone together to say, hey, what can we do for this person? How do we tailor their care? What are their needs? And we see that it works because we're also, we're using evidence-based interventions to work with these patients, and we're also measuring their depression and anxiety every 2 weeks when they come to the clinic. So, one of the gratifying parts is to see patients get better and be able to really monitor that through not just the measures, but the social worker, the psychiatrist, the palliative care provider who are meeting with them is then letting this team, this collaborative care team, know they're doing so much better. Their pain is under control. Their depression is better. Look at how their anxiety has gone down. It's just a really patient-centered way to work with cancer patients, and I think it's also, I mentioned burnout before. I think this is a really good way to think about how we can support each other. You're not worrying alone. When we have our weekly meeting, the social worker will say, here's what I'm worried about. I'm worried that this person is, has dropped 10 pounds. I'm worried that they seem more depressed. I'm worried that they are not bringing their caregiver to appointments anymore. But you're not worrying alone, which is so much of what causes burnout, is feeling like you're the only person who's carrying this. And this model, because it's an interdisciplinary model, I think really, lets everyone on the team know, like, we're here with you. We'll figure this out together, which I think is just very powerful.
I'll just add, perspective that, we're here at this great conference at NCCN, and we have these amazing, evidence-based, practice guidelines. But how do you get it to people? It's kind of like having a great medication, but not having the right delivery method, the right capsule. So, collaborative care, integrated, mental health care is basically, the capsule by which you deliver the potent medication, which, is the evidence-based practice guidelines that we have through NCCN and others. And it's kind of the foundation by which you can build, an interdisciplinary psychosocial program. It's not the intervention itself, it's the delivery of how do we deliver the best interventions, the most evidence-based interventions in an efficient and cost-effective way.
Can we back up a moment and you define collaborative care?
Yeah, it's a bit of a tough term because it's so accessible, which is great, but it's also something that everybody feels like they're doing because everyone, I'm sure, in this room collaborates with their colleagues, and so But collaborative care is a system of delivery that has kind of some core principles. I already mentioned the population-based approach, and that's a critical one because we want to make sure that everybody that we're responsible for gets the psychosocial care that they need. It's a team-based, evidence-based approach. So delivering evidence-based treatments, but in a team-based approach. So you're never, as Amy mentioned, you're never feeling like you're alone. It's not just falling on one person. It's falling on a team of different disciplines. It's measurement-based, so we in mental health have come to measurement-based care a little late to the game. Most oncologists have been doing this for decades, and we've only been doing it, not that long. So using validated instruments to really monitor outcomes over time. Of course, a patient's subjective response is important, but we also want to be objective in the way we can kind of measure, kind of like a pain, 0 to 10 measurement. We use things like the PHQ-9 and the GAD-7 to track, depression and anxiety. And it's very patient-centered. We all know that a lot of people aren't that interested in medications. They don't want to add another medication to their regimen of 25, meds that they're already taking. So we have to kind of, talk about what's acceptable to them, what's not. Some people only want medications. They're not into talking. So we want to be able to provide that. So it has to be super patient-centered, and oftentimes it's our clinical social workers that have the best staffing in many cancer centers, who are kind of the point person to be what we call a care manager. So those are some of the core principles of collaborative care that really kind of come together and provide the capsule to deliver these great clinical practice guidelines.
And I'm glad you mentioned that, Jesse, in terms of different places have different resources. So I've been at a couple of different health systems around the country, working there, working at those places. And some places have robust amounts of resources, and then other places do not. Some are very embedded in rural areas where they may not have all of the resources at that particular hospital or health system. And sometimes, you hear things like the collaborative care model that sounds amazing, but you also have concerns that, well, I don't know if I have that capacity at my site. So I wanted to acknowledge the fact that institutions are different in terms of the resources that they have, so the collaborative care model will look different in terms of personnel in one place compared to another. Maybe you don't have a nurse navigator or a case manager or a social worker or a psychiatrist or a psychologist, and you still figure out how to get it done with what you have. The other type of model I want to also introduce is age-friendly care models. We have a fast-growing older adult population in terms of cancer prevalence, incidence and prevalence, and it's important to acknowledge that systems are recognizing that patient population, that prominent patient population, and what that means in terms of the assessments that they conduct, such as geriatric assessments. And you may be thinking, well, a lot of those are function and physical in nature, but it's meaningful to older adults when they're not able to get up and get out of bed because of cancer. That impacts their mental health, and that impacts how they normally see their need to thrive or lack thereof. So when we conduct assessments, geriatric assessments, where we look at falls risk or comorbidities, medication, all of the medications that they may have, any potential risk for polypharmacy, anything that may impact their cognition in addition to the cancer treatment. Those are important to assess, because what we find meaningful, we're helping to fix their cancer, is maybe destroying other aspects of their lives that are really meaningful to them.
Mm-hmm. And is that also an interdisciplinary approach?
Yes. So one of the personnel that we haven't talked about are geriatricians in the room and palliative care. We've talked about palliative care clinicians. But being able to think about the whole team, sometimes that includes physical therapy, occupational therapy, sometimes that includes music therapy. We know that music has such an influence when it comes to cognition. Recreation therapy, so a lot of my work is in pediatrics, but recognizing that recreational therapists are essential when it comes to adults and their well-being and hobbies and identity. So there's other people in the room that we need to include when thinking about age-friendly models, care models.
And what happens when we all don't have access to all of those people? So you mentioned that it's going to look different in different places, but I think referring specifically to the model that you were describing, Jesse, my understanding is that doesn't mean that you need a psychiatrist at each site, right? Often there's somebody on the team who's face-to-face with the patients, but there's different types of kind of oversight and interaction in patient care.
Yeah, absolutely. I think we have to be flexible, and we have APPs on our team that can do a lot of the medication consultation, and a lot of places don't have a psychiatrist. One thing COVID did bring to us at most of our centers is telehealth, so we can deliver remote consultation through telehealth for medication management as well as behavioral strategies. A lot of places have nurses who can be kind of the point person, the care manager. So I think you have to be flexible, you have to be creative, but different people can deliver the core components of a really robust interdisciplinary program, and you just have to kind of be aware of the core principles that you don't want to give up on. You want to use what resources you have to be able to deliver those core principles of really good evidence-based care.
Yeah, definitely. In our model at Dana-Farber, we meet virtually as a group every week. The psychiatrist is, making recommendations. It's not always a recommendation for a consultation with psychiatry. Because our model started in our satellite sites, many of our patients don't want to go to Boston. The traffic is terrible. And they don't want to have to make the trip in. So, if we can, they can do a virtual visit. We actually are trying to even arrange that visit with the psychiatrist virtually at some of our sites. We're kind of trying that out now so that the patient would come to the satellite site and could see the psychiatrist virtually there. But the psychiatrist also makes recommendations to primary care physicians, to the oncology team, our palliative care providers, can also prescribe medications. And so I think that's another aspect of this model that is so good for patients, is that they know that a whole team is looking out for them and that the team is communicating. So the oncologist can look in the medical record and see, like, okay, the psychiatrist is recommending this. I'm comfortable prescribing that. We're going to move forward. And I think that is, another way to utilize psychiatry when we know that there are absolutely communities that have, very few psychiatrists, and that there are just unfortunately fewer psychiatrists. It's a profession that I think we need more of. So that we can meet the needs of patients when they have, medication needs, or when oncologists have questions about medications that patients are already taking, or how cancer medications may impact their mental health. I think that's where the psychiatry role is really important.
And I also want to share, in resource-limited settings, we talk about clinician capacity, but oftentimes I've had patients and families who don't even want to talk to clinicians. They're like, I'm tired of talking to clinicians about, physical burden and symptoms and medical-related jargon, and sometimes they want to, it's not necessarily a huge disadvantage for not having all types of clinicians in a setting. Sometimes you have to lean in on the non-clinician. So, we know that there's individuals, including chaplaincy. Dana-Farber, before I left, there was a robust peer support program for caregivers and for patients in different specialties. So, which is really important because you may not want to talk to a breast cancer survivor if you're a, heme, if you have a lymphoma or a leukemia diagnosis. So those peer support programs are essential, but in the realm of telehealth, as Jesse mentioned, sometimes people are just lonely and that impacts their mental health. So being able to just talk to someone, having that sense of belonging and connection is also wonderful. I know at Dana-Farber they have this great young adult lounge. So I'm curious about Stephanie's experiences when it comes to in terms of patients reaching out to community and faith organizations for connection.
Like you said, in a non-clinical setting, a lot of times people are so overwhelmed and feeling so burdened by all the clinical aspect of it that you also don't feel like a human. You are a patient, period. And so I think that's why I will always emphasize the importance of community resources, because feeling a part of a community instantly removes that feeling of being isolated. And again, it all intertwines with your mental health. And I think once you don't feel isolated anymore and you feel like you have a grasp on things because others do and others have been in your shoes before, makes all the difference at certain times. And I agree that I see a lot of patients who want to talk with someone, especially in the young adult space, similar in age. It's still such a smaller volume in adult cancer centers than older adults. And so connecting someone with, again, a similar diagnosis, similar in age, it makes all the difference. And even I have breast cancer survivors who say, I don't want the breast cancer space. There's so much breast cancer out there. I want a non-breast cancer community and support group. And so we can cater to all of that. Thankfully, nowadays, there's so many more resources than there were in the past. And if you don't know what resources are available, somebody does. So reach out to anyone on the team. And if someone doesn't know, lean on your colleagues, because at some point, somewhere, we're all interconnected as far as the resources go. And there are so many right now. So to your point, I completely agree. And sometimes support groups do well in a clinical setting, and sometimes they don't. I have seen patients who, they want nothing to do with the cancer center. Once they're done, they're like, I'll come to a support group, but if it's at the hospital, I'm not going, because it's triggering. And so that's another topic that we can all talk about too, is triggers, during and after treatment. So absolutely, to the community non-clinical space, I'm a huge advocate for it.
So we just have about 15 minutes left, and we'd love to answer some questions. So if you have a question, you can, I believe, come up to the microphone and go ahead and ask. We also have some questions coming in online, so we are not short on conversation.
Hi, good morning. I have a question and a comment. My first question is for Jessica. I am the director of a national peer support model organization for pan-cancer, and we use the distress scale on the daily as we assess, the psychosocial needs of the patients and caregivers reaching out to us for support. My question for you is, one, I would love to speak with you after this to address my needs, but are there any potential updates or changes to the distress scale, or will it always stay the same?
That's a good question. So the distress scale has gone through a couple revisions in the last 5 years or so, but we did one major revision a few years ago for the distress scale and problem list. The distress management guidelines are updated every year, sometimes twice a year even. So that's always available on NCCN specifically. Did you mention caregivers?
Yes.
Okay, so there's not a caregiver distress scale.
Okay.
Tamron, we're going to be outside to continue the conversation after this, but she's done some work specifically on caregiver distress and how to screen for that too.
Wonderful. I would love to
yeah.
About that. And then lastly, my comment, Stephanie, you're a breath of fresh air. I'm an AYA survivor as well. So I definitely understand the major deficits within that community. But I also wanted to make a comment in regards to the ongoing topic of things being in the literature and all of that. Patients are no longer fully addressing any of the preemptive questions regarding mental health in the surveys that were given, simply because our needs are not being met, that go above and beyond being able to reach that, so that those numbers will always be skewed. But additionally, how do we move the resources? Like, I could have benefited greatly from a peer model concept because my physician didn't have time to talk to me about my mental health needs. And I understand that your time is limited, but how do these comprehensive cancer centers can trickle down some of the ideologies into the community centers where majority of the patients are being treated, that we don't have, you know, a comprehensive team to rely on, but mostly the resources from our community? How are you empowering your social workers and your navigators to be able to properly distribute? I know there's so many, but being able to truly address those mental health needs of the community that go above and beyond a psychotherapist or a psychiatrist.
Yeah, I think that that's where the collaborative care model is so valuable. Is that in the model that we use at Dana-Farber, the social worker is the first assessment, the first point of assessment. The model that we use at Dana-Farber, and I think this is probably true for many places, is that anyone can make a referral to social work. So, I've had referrals come from the person who's at the check-in desk, who's the administrative support in check-in, who've said, like, hey, this person is struggling. We also know that you're correct, that sometimes the scores don't coincide with what we're seeing in front of us, and that's why I think, yes, we're looking at scores and measures, but we're also, meeting with the patient and meeting with their caregiver. So we know that they are, they may be struggling even though their scores may not reflect that. So I think that's where this model is really helpful to sort of be able to catch people who may not have been, necessarily referred to social work or may not have necessarily met the threshold with their distress screening.
Yeah, I think any system that you have needs to be sustainable. And, while collaborative care is a billable, service, it has CPT codes, which helps its sustainability. Another kind of core component of it is that it's a very stepped care approach. So a lot of people do very well with support groups and peer supports, peer counselors, community resources, and those are the things that should be, tried first for a lot of people. But then you have to kind of track, how they're doing, and maybe some people don't. That's not enough for them, and then they need to be stepped up to seeing one of our social workers or seeing one of our psychologists, or maybe even eventually seeing a psychiatrist for medications. But we want everybody to be getting what they need at the least cost, because cancer care is expensive. So it has to be a stepped approach, and distress is a continuum. It's not an all or none thing. So we have to target the resources to what people actually need.
All right, we have another question.
So, great. Appreciate y'all, your input. I'm a part of a 12-hospital system in Kentucky that each location has a wide variety of degree of support, some smaller communities, some larger. None of them are in an academic setting. We're blessed to have embedded within my own clinic, 25 feet away from me is our full-time psychiatrist, palliative care, and that's wonderful, but not all of them have that. So I think that trying to figure out how we partner, even not within our own systems, I think that's part of what this place is about, is figuring out how there's no walls really. It's about getting people where they need to go to get the care they need, and if you can't provide it, figuring out a default. And I think that's my challenge to you. So on the one hand, I think recognition is the key, and I think basically it needs to be an assumption that everybody should have the opportunity. And I'll tell you how I go about it. I don't have in a 15-minute appointment, I can't, in the midst of telling them everything as an oncologist, I can't go into all the details and tell them about their medication and their diagnosis and all those other things. But I give them permission in part by saying, listen, when I tell you that I think it's a good idea that you see our counselor, psychiatrist, or whatever, part of our palliative care team, I said, the reality is I think every one of my colleagues do. So when you recognize the burnout part of what we're going to talk about today is actually a bridge where we meet our patients on a common ground of this battlefield of cancer, and you can use your own vulnerability as a clinician in that room with the patient. I find that to be one of the most healing things, is when I come down to the human level and I quit talking about, you know, this abstract cancer, but how their own diagnosis gets my heart. And when you go to the heart of the patient, man, that's where the real therapy happens. So I wonder how you, as clinicians, balance this universal access with appointment overload. You know, if it's like, well, everybody's going to get it and you're going to have to opt out, like, you know, there are different ways to check out. One of the ways to do this is everybody who checks out gets an automatic referral that they have to deny. On the other hand, is it better to do the more incisive, like you try to figure out? A lot of the people who need this, the recognition as a clinician, the recognition's the hard part, because some of the people who need it most have the best theatrical skills, and you are. I will admit, I need, like in Star Trek, I need Troy. You know, tell me what the Klingons are feeling. You know, because I'm in there so into my head about what they're going on with that I'm not feeling them. How do you balance the approach that I think everybody needs this, but at the same time, how do you then recognize that they're going to optimal teams? They're going. We're nutrition. All of, you know, genetic counselors, all the barrage of things that they're going through. Do you think it's best done by a default, or do you have incident related that you're using your own sort of innate sense to decide when to click that button?
So ideally, this is available to everyone. I completely agree with you. I mean, I think that about mental health care in general, even outside of cancer. However, that's not our reality. So we at Siteman use the distress screening as that tool to identify who needs the additional mental health or social work or chaplaincy support. I believe models like we talked about, and unfortunately we don't have a lot of time to answer this. I think models that we talked about are better at identifying who would most benefit rather than the patient. We don't need to rely on some sixth sense or something like that, because that doesn't work.
Yeah, this one's been waiting.
Guys, thanks to acknowledging the side microphones. My name is Kathy Jankowski. I'm an exercise physiologist, University of Colorado. And we know some of the most consistent evidence for all types of cancers at all ages is to increase physical activity, even a little bit, for improving quality of life, reducing fatigue, reducing mental distress. So, though I'm of course preaching to the choir, but what would be the best way to connect your patients with exercise oncology, also keeping in mind that the most benefit of physical activity is from going from zero to something, not from zero to the marathon. So where can we best connect, also recognizing, as my colleague would like to speak of all the financial burdens, getting up and going for a walk is one of the least expensive therapies available to the most people. Thank you.
Yeah, I mean, I could not agree with you more. I think I do think that it's difficult for patients to balance cancer-related fatigue and all of their responsibilities that are going on, you know, within their treatment and outside. I often, you know, will use behavioral activation as a way to sort of help patients to think like what's possible for over the next 3 days, for example. I'm a big believer in fresh air. And so sometimes for patients who are either significantly disabled by their cancer or by their depression, even just opening a window and taking in some fresh air, trying to get people to think about, can I stand up more? Can I move more around my apartment? I also live in a part of the country where the weather is terrible for a lot of the year. It feels like a lot of the year. And so I think that we definitely, as social workers and, you know, in the mental health field in general, have to work a lot with patients around that winter seasonal affective disorder as well. So I completely agree with you, and I think it really comes down to trying to like think about how to break pieces of that off and offer it on, what can you do over the next 2 days? What can you do over the next 3 days?
And strategies in motivational interviewing are especially helpful here. It's not enough to say, I just want to be healthy. Yeah. I want to be healthy, why? So just a few brief questions there. We only have about a minute left, so I think we have one more question. As a reminder, we will be outside in the continuing the conversation section, so if you have more questions, please stop by. And I apologize that we didn't get to everybody's questions and everybody's questions online too.
I'll be brief. My name is Cheryl Riley. I'm an oncology nurse advocate, and I want to applaud all of you for the excellent work that you're doing. This topic, I've been in nursing for 40 years, and this topic was never talked about years ago, so I applaud all of you. And exercise therapy, as my colleague said, not only during treatment, but survivorship is huge. They ring that bell, and like you said, oh, hey, everything's great, but they're feeling like, oh my God, I don't know what to do. But if I can leave you with one thought, and I think two of my colleagues over on this side mentioned it, communication with the community oncologists. Yep. Those of us in the community who are not attached to an academic center do not have the resources that all of you have. Mm-hmm. And we need a way to connect our patients with that and not have it cost a lot of money. So that collaboration and having everyone looking at the same notes, being connected interdisciplinarily, and that part of that collaborative team approach should be including community and having that internet connection so that the community physician knows that there's psychologists here and there's an exercise physiology program here and so on and so forth. It's not always the physician that's going to do it. It's going to be the nurse advocate or the nurse navigator. But I want to leave you with that thought. And thank you all for all of your work. And congratulations on your survivorship.
Thank you.
Thank you.
Let's end with that because we completely agree with you, and I think we can all do a better job of making sure these resources are available. So we're heading into a 20-minute break. You're welcome to visit the exhibit hall and posters in Palms 2 and 3, or come join us at the Connection Hub in the Palms foyer to continue the conversation. Thank you all.